Welcome to the Stoic Bodywork podcast. I'm Octavia, your co-host. Just a quick reminder, all the information shared here is for general informational purposes only and isn't intended as professional, medical, or legal advice. And since today's a guest episode, the views and opinions expressed by our guests are their own and do not necessarily reflect the views of the podcast or any associated institutions, education systems, or organizations. All right, let's get started.
Welcome to another episode of the Stoic Bodywork podcast. My name is Phil. I'm the host and creator of the podcast. And today I am joined with Dr. Nicole. Nicole, why don't you tell us a little bit about yourself?
Hi. So I am a medical oncologist. So basically, to understand that the best, I give chemo for a living, and other stuff, which we'll talk about in the podcast. I work at a large community hospital, and where my field is going is it's so wide and there are so many different diseases and there's so much research that we tend to subspecialize in things we are interested in. So the majority of my practice is breast cancer. I have been in practice for about 14 years now.
Okay. I didn't know you were in practice for 14 years.
Yep,
what did
I'm
you
old.
start in? DO? You were a DO, right?
Yeah, I'm a doctor of osteopathy.
Okay.
Yep.
And when did you start that?
I started med school in the year 2000, graduated in 2004, and I did a year internship. So DOs have to get extra credits for their licensing. So I did an extra intern year of kind of like more primary care based stuff. And then I did internal medicine for 3 years. And then you do 3 more years to specialize in hematology oncology. So it's a dual specialty. We do benign blood disorders like bleeders and clotters. And we do leukemia, lymphoma. So like hematology, you cannot extract from oncology. All the chemo you give messes with people's blood counts. So we're actually like dual boarded in both hematology and oncology.
Okay. So you started off pretty early in your career then?
Yeah, I started, let's see, I was a little late to med school because I didn't initially know I wanted to go to med school. I majored in engineering, believe it or not. And I did an internship and I didn't like it. And I happened to see the movie Office Space around that time. And I saw my future.
Okay. All right.
So I decided to go to medical school. So I was a little late. I started med school when I was 24.
All right. Well, I mean, that's honesty for you. So I have a bunch of questions about cancer, obviously, and we're going to go through them. But I think, honestly, we'll just get right into it. So let's start with, what are the most effective ways to reduce the risks of developing cancer and like lifestyle choices that can affect that?
Well, number one, I don't think this will be a shock to anyone, is don't smoke cigarettes. And also don't vape. There's still nicotine in those vapes that you buy over the counter, and God knows what chemicals. Like, I don't even think we understand the full impact of all of it. So don't do that. The American Cancer Society categorizes red meat as a carcinogen. So try to limit your red meat, processed foods, processed meats. Every study we've ever done in oncology shows that exercise is good for you. Outcomes are better. So exercise, absolutely important for many reasons. Even, I always say the reason I exercise is for when I get my catastrophic illness that I can get out of bed afterwards, after it's over. So even if you do get sick, just being in general good shape going into it is the biggest predictor of how you'll come out of it, no matter what that thing is. Using sunscreen and also vaccinations. So the human papillomavirus, the HPV vaccine, some know it as Gardasil. That's the trade name for one of them. If everybody got that vaccine before they became sexually active, because HPV is a sexually transmitted virus, that virus is an oncovirus, so it can cause mutations in cells of the cervix, the anus, and the head and neck. We could eradicate HPV-associated cancers if everybody got vaccinated before they become sexually active. So, like, my generation, I'm about to turn 49 next week. Like, my generation has been almost universally exposed. It's very ubiquitous throughout the population. So you got to catch people before they become sexually active.
Interesting.
Go ahead.
Is that vaccination part of I'm thinking it was part of the schedule when I was in like high school.
Yeah, you're younger than me.
I'm in my late 30s.
Yeah, so it could have been like you may have just caught you. I can't remember what year it came out.
But it's on the schedule now. But I think they give it to you when you're older, right? Like
it's usually it's kind of an uncomfortable conversation to have with like the parent of a 9-year-old.
Yeah.
But I think it's around that age, like early adolescence.
So parents should be aware to think about that before their child becomes sexually active.
Yeah, which is like, not fun for parents to think about.
Yeah,
But
difficult
most
conversation.
pediatricians, it's part of the conversation, part of the standard conversation. It's not a required one for schools or anything. So I don't think there's universal vaccination. But it's not something I deal with regularly. Like I told you before we started this podcast, I'm in the business of fixing it, not preventing it.
That's fair.
So I don't have a lot of those conversations with patients because my patients are not pediatric. But overall, I think the vaccine's well tolerated. I don't know of any like severe side effects. After any vaccine, you can feel a little achy or feverish. But I haven't heard a lot of problems with it. So I would absolutely recommend to anyone before your child is sexually active, get vaccinated.
Okay, that's good to know. Before we go farther on that topic, as far as like lifestyle choices and things like that, I'm a big fan of definitions because I think people don't understand words sometimes. And I think the one that gets most misrepresented is carcinogen. What is a carcinogen? What does it do?
I mean, carcinogen can be a lot of things. We're, I think, surrounded by it. Typical stuff, Agent Orange. I have patients who are veterans who have 3 different types of blood cancers and lymphoma all in the same body. I mean, that doesn't happen without some kind of serious exposure.
And are they typically always chemicals?
Well, like, I guess technically, like, there's radon. Radon's a chemical. All the stuff in nicotine products, those are carcinogens. So, yeah, usually chemicals like benzene, toluene. I'll never forget, I had a patient, I was on call Christmas Eve, and he came in with acute leukemia, and he was a chemist who worked with benzene and toluene. So
I might give it away.
Yeah, sorry. I think it was work related.
Okay. So the word carcinogen, gen is, see, I take it from the Latin side. So like gen just means to populate something or to initiate something. And then a carcin would be, essentially something that causes a mutation in a cell. So most carcinogens are creating mutations in cells, right? And so they can be, what?
Chernobyl.
So yeah, like skin contact would be enough for you to absorb a carcinogen, correct?
Yeah. I mean, inhaling skin contact. And then, I am seeing patients who were in the vicinity of Chernobyl in 1986.
That's crazy.
Yeah, who've had a couple different cancers.
I might come back to that one.
Yeah. And I don't think I appreciated Chernobyl, but HBO did that miniseries on it.
Yeah.
And that made me so emotional.
It's rough. That's a rough one. I don't like, there's stuff
especially the episode with the dogs.
Yeah. Anytime there's animals involved, it's kind of like, all right, that's rough.
But also I suspect that plastics and forever chemicals, we are going to find to be the lead of our generation.
Yeah, I mean, you never really know what the manufacturing process is for a lot of that stuff. And as much as plastics are amazing, everything is a byproduct of the petroleum industry. And we already know that petroleum isn't, by definition, a carcinogen in some ways. So yeah, I'm sure that'll come out eventually, but it's just so hard to get away from. Which, getting back to, is there any other lifestyle choices you would recommend there as far as, or can think of that you would, no smoking. Obviously, I smoked when I was a kid and that was a terrible decision, but vaping definitely. I didn't get into the vaping thing, but I'm happy I didn't because you hear about like popcorn lung and all that stuff. It's just crazy. Nicotine I've always seen as a nootropic, but like you can't swallow it because then it's causing irritation. So I know a lot of people out there are like on the Zinnies and stuff like that. Yeah. That kind of worries me a little bit. But any other, sunscreen, things like that, any other lifestyle choices there?
I mean, you can try to avoid plastics, but I think it's easier to cure cancer than it is to avoid plastics these days. Like I have tried to buy different water bottles, metal water bottles, and then I'm like, oh, well, the straw I'm drinking from in this water bottle is plastic.
Yeah, that's not getting away from that.
So yeah, I try to like buy more glass to especially microwave things in. I haven't studied a lot of the science behind it, but They can measure these chemicals in our bloodstream.
I think they measure them in our water now.
Yeah.
Like,
It's
if they're active in water, they're active in your bloodstream.
I know. So like I'm not well versed on it, but boy, it seems a little cringy to me.
It's fair. So on that progression, what are some of the warning signs people should be aware of? What kind of symptoms or even lifestyle changes that they might not even notice? For body work, it's easy. I tell people, like, if there's dysfunction, you see it, right? If it's in the fascial system, you're going to see it. For cancer, I think a lot of people could go a long time. I mean, that's probably where it becomes progressive in the stages and they don't know about it. So what are some early symptoms or any signs that they should look for?
I think any woman, regardless of age, if you feel a breast mass, don't ignore it. Even if you're in your 20s. I have patients in their late 20s who have breast cancer. And especially women of younger age are the ones who tend to get blown off when they come with that complaint. Although I think the medical community is getting more and more aware of the phenomena of breast and GI cancers skewing younger now in age of presentation. So if you feel a lump, don't ignore it. Your primary care physician can order, an ultrasound. The tough thing is under the age of 30, mammograms are not great because your breast tissue is so dense when you're younger.
I was just going to ask, do you recommend regular mammograms?
I think even the primary care guidelines now have across the board lowered it down to starting at age 40 for mammograms. But if you have a family history of breast cancer that, at young ages in family members, we always say start 10 years earlier than the youngest age of cancer in your family. So if your mom had breast cancer at 35, you probably want to start with breast cancer screening at 25. But the problem is, like, a mammogram's difficult because of the dense tissue. So other options are breast MRI and ultrasound. Like, if you feel a lump, it's easy enough to ultrasound it. But when you feel something, it is kind of bigger than you'd like to find it. So if you're doing true screening where you're completely asymptomatic and you don't feel it, under the age of 30, breast MRI is a better tool. Because you can just get a better picture in denser breasts.
And they just talk to their PCP about that?
Yes. There's like risk model calculators. One's called the Tyrer-Cuzick model. And if you hit 20% or greater lifetime risk of breast cancer, then your insurance should cover a breast MRI.
Oh, okay. That's good to know. Yeah, I think that's part of a hard thing is like navigating what you do on the financial side of that. Like, if I have to get regular testing.
Yeah.
Well, I'll let you continue with what are the other warning signs?
But it's like if you feel something, don't ignore it. Blood in your stool. So like, who doesn't have a hemorrhoid? But, I can think of patients who had blood in their stool or any like changes in the caliber of your stool or the patterns of your stool, new onset constipation, thinking about getting a colonoscopy. If you have a first degree relative with colon cancer, you should start colon cancer screening at the age of 40 or 10 years earlier than the youngest. So let's say your dad had colon cancer at 35, you should start colonoscopies at 25.
Interesting. And we are going to get into some of the genetics there. But
yeah. So, if you see blood in your stool, you shouldn't ignore it. Okay. I myself have had 4 colonoscopies, so I'm not asking my patients to do anything I haven't done 4 times.
One of the reasons I brought you on was I was like, she's kind of like me. Like, I only do things for people that, like, I'm like, yeah, I've done that. You should do that. So it's kind of one of the reasons I was like, yeah, I'll listen to her.
Yeah, there is that Cologuard test where you poop in a box, basically, and send it in. It's not good enough if you have any symptoms or if you have a strong family history. It's basically for screening for the absolute most general risk patients. And the other thing to understand about colonoscopies is it's a preventative test, because if they go in there and see a polyp and they remove it, polyps are what become cancer. So it's not just screening, it's prevention.
So before we go farther on that then, how is a polyp defined then?
A polyp's they can be little flat things, or they can kind of have a little stalk with like a ball at the end.
Okay.
They're benign and they have different types. But the benign polyp can become a colon cancer down the line. It can kind of mutate and become cancer. So if you remove that, it's actually a preventative test.
Okay. Because what I was going to add with the, if you feel a lump, get it checked.
Mhm.
When I started my career, honestly, licensure for massage therapy didn't exist. Body workers were what we did.
Mhm.
And so when I was learning, I learned from a doula who also was like a lactation consultant. And she regularly did like checks. Like she was like, I'm already doing this if you're comfortable with it.
Mhm.
And so she talked to us about it. And I remember I didn't actually, like, obviously I was a male in the situation, so I didn't do any of the actual palpation or anything like that. But she had someone who had a polyp in another area. And she was like, I was like, if I didn't know what that felt like,
Mhm.
I probably would just pass it off as like adipose tissue that was hardened or something like that.
Mhm.
So even me as a professional back then, I was like, what is this? So I think people go like, am I going to know? You kind of know. Cause like if you press on them, people go like, that feels funny or weird. So just from that side of things, like the palpation side, yeah, if you palpate something and you think it's weird, you probably should get that checked out.
Yeah, especially in this era of younger and younger cancers.
So any other early warning signs that you would want to mention?
Unexplained weight loss.
Okay, that's the one I'm always like, it can explain a lot of things,
Yeah.
but I have found, people pass that one. That's the one they're like, oh, I just lost a ton of weight. And I'm like, no. You should look at that. What happened?
I'm always skeptical. And I've actually had some situations where patients were on like the Manjaros and Ozempics and lost a ton of weight, but they actually had a lymphoma.
No way.
And no one questioned the weight loss because they were on a weight loss medication that actually works really well.
Interesting.
Yeah, they were okay. We still dealt with it. But yeah, so unexplained weight loss, I'm always skeptical of, especially if you're not on drugs for it.
I mean, look, I'm not the medical professional here. I never will say I ever am. I've seen it too many times where an unexplained weight loss in any way, even if like we have, we do physical training here. If I see a client who drops 3 to 4 pounds a week, something's going on. That's not normal because I'm targeting. And I think that's something for professionals in the wellness industry to be aware of. If you're working with a client, it's hard to gauge those situations, but I don't think it's ever wrong, nor is it, they say sometimes it's outside your scope of practice. I don't think it's outside of your scope of practice to say, hey, we were targeting 1 to 2 pound weight loss and you're well over that. Let's check in with your PCP. Like, I just think that's a good thing to be mindful of because when you're seeing 4 or 5 pound weight losses, if they're not morbidly obese and you're just expecting that to happen, yeah, very rare and odd.
Well, and I mean, even just checking the thyroid, checking for
like something else is going on.
Something, yeah.
Okay. Let's see. What role does early detection play in improving cancer outcomes, and which screenings are most important? Because we kind of talked about some of that already.
Yeah. No, I mean, early detection is absolutely crucial. So right now, the screening recommendation is to start mammograms at 40, and I can tell you the American Cancer Society says yearly. There were some primary care guidelines that were saying start mammograms at 50 and do every 2 years, but I think they've even changed them because of what we're seeing with increased incidence of breast cancer. So I would say start at 40 unless you have a family history that would indicate otherwise, and do your mammograms yearly. Mammograms are good. They're like 3D now. The technology is really good. They pick up a lot. So
yeah, one of the ones that I get most often is I don't like it because it pinches the breast tissue and it's uncomfortable. I feel like it depends on where you go. Is there any recommendation that can be made for like, how does someone, like, obviously you go to your PCP and you start that process, but is there like, who does the majority of the screening, I guess is the question. I think a lot of people wonder, specifically on the female side for screening, where do I go to get this other than starting the conversation with my PCP? What options are available?
I mean, I think any of the big community centers are going to have like breast health services. And, a screening mammogram access to that should be pretty easy because there's a difference. There's screening mammograms and then there's diagnostic mammograms.
Oh, okay.
So a diagnostic mammogram is, I feel something. So if you have to get one of those, you have to go to like a more specialized center. Because when you get a diagnostic, the radiologist is there and they often will also ultrasound it and look at it when you're there to see how suspicious it looks and if any biopsies need to be arranged.
So it's more of a more intensive.
Yeah, it's like the radiologist is there to look at it. It's not just like a tech doing the study and sending it off through the computer to be read later.
Okay. So as the male in the room on the outside looking in, that sounds like it could be a little bit like when women talk about these things, because I know sometimes these subjects can be a little taboo. I even get it with my bodywork practice because people ask me, like, hey, you have a background in female health. I'm like, I do. What would you like to know? I wouldn't even have known to tell that, like, oh, there's these two different runs. So I wonder if sometimes you hear, like a young woman will hear from their friend, oh, I had to go get this done and it was so intensive because it was that more diagnostic side.
Well, and that's what you do if you feel something.
Okay.
But like access to screening mammograms, I think it's pretty readily available. And
that's a fairly quick process?
Yeah. I mean, when I get mine, I'm in and out of there in like 10 minutes.
Okay.
Does it suck? A little. Yeah. Having your breast squished and like standing up in this awkward machine. And like sometimes the thing comes down on your clavicle and it's unpleasant. But what hurts worse is stage 4 breast cancer metastasized to your bone. So let that be your mantra.
That's a fair.
While you're sucking it up and getting through it.
Fair statement.
And you know, when breasts are small, it's kind of harder to like get it all up in there.
Okay. Is there, I mean, I don't know if this is an appropriate question, but I've actually had it asked to me. Is there any correlation to a woman who has larger breast tissue to a woman with smaller breast tissue as far as the numbers go? Like, do we see anything there?
No. Really, like risk factors, like when we do general risk model calculators for breast cancer risks, if you have had more children at an earlier age, that's more protective for breast cancer.
Interesting.
Having a family history will up your risk numbers. Your age at menarche, when your period starts, that affects it. If you've had prior breast biopsies, and if those breast biopsies have found like atypical ductal hyperplasia or something called lobular carcinoma in situ, those are like pathologic characteristics under the microscope that show like reflect an increased risk for breast cancer in the future.
Okay.
So all of those things are like general risk calculators, and then you know, I think we're going to talk about genetic testing a little later, where certain genes can also increase your risks. But amount of breast tissue, no.
Okay.
Breast density, I think, affects your risks in the sense that really dense breasts, when you look at that mammogram, it's like trying to see something in the middle of a snowstorm whiteout. So it might make the mammogram a little less sensitive, and that's where we think about doing breast MRIs.
Interesting. All right. So before we go past that question, because you mentioned like if someone's had a pre biopsy, if they've had to go through that process, does their doctor at that point recommend a certain time schedule for them to get mammograms done or to get like more testing done? How does that work?
Well, it's like when you do your risk model calculators, if you've had breast biopsies with atypical changes before, likely your numbers are going to hit a lifetime risk of 20% or more, and then you would meet criteria for breast MRI. So usually what we do, insurance will not cover mammograms, like screening mammograms, any sooner together than 1 year. And same with breast MRIs. There has to be a year in between.
Okay.
So I alternate them. Mammo, 6 months later, MRI, 6 months later, mammogram, to try to get sooner time points in there.
Gotcha.
Now, there's a flip side to breast MRIs. Breast MRIs are a very sensitive test. So when you have a very sensitive test, you're going to find more false positives, AKA we see a thing, we biopsy that thing isn't cancer. And breast biopsies aren't fun. And, you know, depending on your insurance and your deductibles, breast MRIs are expensive. So you could get hit with, you know, $500, $1,000 bills. So I think it's important when you're going to order breast MRIs to discuss all that with the patient. You know, what are the limitations of the test? And what we can't really show with MRIs is a survival benefit. So with first MRI, if we're going to find something, we tend to find it 6 months sooner because you're getting an extra screening time point. But does that actually make anybody live any longer? Especially if it's like a real early stage estrogen sensitive breast cancer. We actually can't show that yet. So if someone tells me no to breast MRI, if they don't want to do the extra screening, like I don't fight them real hard on it.
All right. And I think what I would probably add on that is your specialty is in breast cancer.
Yeah.
So this is probably true for most, like, we'll put the blanket statement out there, like as far as screening goes and as far as all those other things, a lot of this stuff is going to carry over into other types of cancers as far as getting screened and some of these risk factors and how to go about getting regular measurements. But I think you would say having those markers are probably one of the most important things, because if you don't have them, you don't have a lot of data to go off of, right? Like if you don't have a mammogram that was done pre-finding something, it's hard to figure out like, okay, well, what kind of mass is this? How did it develop? What the size changes are.
The character, changes over time, like your baseline image and changes over time. Because sometimes they'll see something and it's probably nothing. And they'll just recommend then a 6-month follow-up study. Usually actually another mammogram, which if the radiologist recommends it, then insurance will cover it in 6 months.
Okay. So that kind of takes us into our next question, which is, what kind of questions should patients or the representatives be asking? Like, what should they be advocating for when it comes to getting these tests done? Or if they have gotten a diagnosis, what things, or maybe they forget to ask or don't know to ask?
Well, I think especially young women tend to get blown off when they feel a lump. Another challenging situation is feeling a lump while you're breastfeeding. I have treated multiple patients who are pregnant or found the mass when they were breastfeeding. And, it could be a clogged milk duct, it could be something else, but like I'm the queen of paranoia. If you feel something, you image it, at least put an ultrasound on it. And if you go to your doctor and they won't do that, your PCP, then go to your GYN and keep advocating for yourself and keep demanding imaging studies, because just because you're young, just because you're pregnant, just because you're breastfeeding, just because you don't have a family history doesn't mean that can't be something.
So they can get passed over pretty easily because of those
So
things.
advocating for yourself, if you have something on physical exam, to even just get an ultrasound. It's cheap. There's not even any radiation exposure. Yeah, sometimes you really have to advocate for yourself.
And their OBGYN can be another avenue for them to ask for those things. Okay.
Yeah, and sometimes it just depends on who you're seeing. Like you may have a visit with your PCP or GYN soon, so that's the doc you go to.
Okay. Anything else they should be aware of as far as like, hey, you really need to advocate or be asking these questions?
It just back to the other alarming signal of, blood in the stool. Don't blow it off. Any changes in your stool, like we said about diameter change, new onset constipation, excessive straining, advocating for getting a colonoscopy. Usually you need a referral to a gastroenterologist for that. But I feel like our attitudes are shifting because we've all now seen so many people with young GI and breast cancers that we're being more receptive to these early screening studies.
Okay, because that kind of gets into, my previous podcast was about self-awareness and mental health.
Mm-hmm.
And one of the things I think gets overlooked in self-awareness is just paying attention to yourself and how your body does things, right? A lot of times I see people in body work because it's an acute issue, right? Mm-hmm. They sprained an ankle, they had this dysfunction, or this isn't working correctly, or this isn't happening. But there's a lot of things that can be preventative just in body work if you're just paying attention to how your body's functioning. Mm-hmm. So things like monitoring, we get it, people, it's gross, but monitor your stool, right? It tells you a lot about your health, specifically when we're talking about gut biome health. There's a lot there that can tell you all sorts of things that are going on. Mm-hmm. So is there, I guess that's a tough one actually. Is there anything as far as because we're going to get into like cancer treatment essentially. Mm-hmm. Is there anything as far as getting, I guess we'll just jump into it, getting a diagnosis that they should be monitoring themselves because it can go overlooked or anything like that? Like, is there any okay, I have, or even if it's benign, like, okay, I've had a biopsy, it was benign, we're moving on. is there anything there that they should be advocating for as far as I need to be, or self-awareness wise, should I be looking for this, or this?
Well, I mean, some other things just to be aware of to bring to your doctor's attention. Any funky looking moles. So, any mole that bleeds, that changes color, that has irregular borders, that's the time to see a dermatologist.
Okay.
And then another thing, just to go on the other side of the spectrum to the other, to older people, any woman who has been in menopause for years has vaginal bleeding. That's also not normal. So like getting your period randomly when you're 72 years old, that's not your period. That could be endometrial cancer.
So I honestly, I know it sounds odd, but I get this one a lot from women who are going through perimenopause, menopause, and they're like, I think I got my cycle again. I'm like, that's not usually how this works.
Right.
You should check with someone.
Yeah.
Right. Because it's, like we're talking about a hormonal system that is on a cycle. And that cycle might fluctuate as you're going into perimenopause, menopause. But if you're postmenopausal and you have any bleeding, that's clearly probably not a cycle restarting unless you've just taken a massive dose of estrogen somehow and started that cycle. Probably not what's happening. So I think that's definitely a good one. I think now we have to jump into the scary stuff that people necessarily don't want to talk about too much, but you clearly treat cancer and you deal with people who have cancer on a regular basis. Is there any advice you would want to give to someone who's going through a cancer treatment?
I think, the first visit when you meet your oncologist, and there are usually 3 different types of oncologists. So there's medical oncologist, me, I give chemo for a living. Sometimes radiation's part of the treatment, so radiation oncologist. And, in the case of breast cancer, what's the cure for breast cancer? It's surgery. All the stuff I do is extra to clean up anything microscopic that might have gotten out of the original place it started. But so those are usually surgical oncologists. So especially for the first visits and subsequent visits, when you're settling in and learning about this, bring someone with you. Bring a set of ears who is not about to go through what you're going to go through so that they can hear and process. It's a lot of information. And it's, if you're a normal human, unlike me, it's not a routine part of your day. It's a lot of foreign words. It's a lot of instructions, a lot of medication management. We give a lot of written down educational materials, but I will give you a personal example. When I was in my 3rd year of fellowship, so that was my last year of oncology training, my mom was diagnosed with an early stage breast cancer. And I will never forget the visit where we found out that she was going to need chemo. Like, I watched her mind exit the room. Like, it was like she wasn't even in that room. It was me and her oncologist talking. Like, she might as well not have even been there. She heard, you're going to need chemo. And that was the last thing she heard. And if you want to get a really good movie that will make you both laugh and cry, it's that movie 50-50 with Seth Rogen.
I don't think I've seen that.
50-50 means they gave the main character a 50-50 chance of survival. And they show the scene where he's sitting there in the oncology office, and his oncologist tells him he has cancer in his spine. And they show it from his perspective, and they show his vision go blurry. They show his ears ring, and you can see like the blurry physician talking. He doesn't hear a bit of it. Like, all he heard was, you had cancer and nothing else.
I've dealt with, because when I did private security work, and I've been in situations in my life where people become traumatized instantaneously. And it doesn't have to, like, people think like trauma is this, I was shot. No, I've seen people get hit in the face, get rocked, and just life doesn't exist anymore. Like, it just blank out. It happens to fighters sometimes. I've seen it with training with EMS individuals who've never seen a dead body before. And they see their first, and like, it's all of a sudden like, I didn't actually think I was ever going to see this. And they just blank. So getting a cancer diagnosis could easily trigger our bodies are just built for fight or flight sometimes. And that could simply become a sympathetic response and just like I need a minute. So yeah, that makes sense to bring someone with you.
Well, it's funny because I'll ask my mom like what she remembers. That was 15 years ago now, and she's fine. She doesn't remember any of it. She barely remembers anything from the experience.
Interesting.
At all. So yeah, it was. I always say like my mom getting cancer in my last year of training was the single most educational experience of my entire training.
It's unfortunate that you had to go through that, but yeah, situations like that, I do find like that's an experience, right?
Yeah,
that's beyond just the training.
Yeah.
Anything else you would want to add there?
Write it down. So get a notebook. I always say the key to every problem and the solution of it is a good notebook and some office supplies. So like write it down, keep track of what symptoms, like especially if you're going through chemo, keep track of what side effects you had on what day. Like accurate side effect reporting helps your doctor help you, helps them decide like, do I need to make dose reductions in your treatment? Do I need to add extra nausea medicine or to help you just kind of manage with supportive meds? So write it down. And even if you are a person of means, ask about social work support. You know, like a cancer diagnosis, depending on your insurance and deductibles, like it can be a financial stressor, and there can be some other like financial resources out there. Like for instance, I sign forms every day that if people are struggling to pay their power bill, I say like it is medically necessary for them to have electricity. You can't shut it off.
Interesting.
Especially like for breast cancer, you know, it is a large community of highly motivated women. And there are a lot of support, like even, you know, financial support for bills. There's all these different advocacy groups and support groups. So ask, like any cancer center will have a social worker who will know what some of those resources are that you could have access to. Let's see what else.
So I'll add on that side with giving information to your doctor. I deal with this every day because we call it the subjective objective. So for individuals who don't know what that means, subjective is the information you are detailing for yourself, like what you are subjectively going through. And then objectivity is like what we do with that information on the, I can't call myself a clinician, but on the clinical side, that's what you do with it. So I always qualify pains like sharp, stabby, dull, achy, burny. Sharp and stabby, that's usually neurological. Dull, achy, burny is typically a bone that's not comfortable in its positioning. Sore, tender, that's the muscle groups, right? So it's interesting to hear that even on like that level of treatment, it's still this subjective objective. So it's really good for people like getting in there in the moment. I have this constantly. People come in and I'm like, hey, you know, what are you feeling? And they're like, well, it was like 3 days ago and I don't really write it down. Just write it down. Because if you brought it in, we're like, I felt this. I went up this set of stairs and I felt this sharp, stabby pain. I've had clients come in with, put a sticker on it, right? If I'm doing regular treatment on someone, you know, we're working through some sort of, you know, maybe it's migraines, headaches. I'll be like, have your significant other or have someone else like, or if you can, put a sticker on that rhomboid that you can't quite reach so I know exactly where to look for it. So it makes sense. You know, yeah, write it down. Bring it to your, you know, primary care doctor, or like in this case, it would be their actual, what is that, their treating doctor? Or
yeah, like oncology. Usually, I mean, like for me, medical oncology, I'm given chemo.
And do they work directly with you then? Like, okay, so so just bring it to you, right? Like in that sense. Anything else you want to add before we move on?
So beware support groups. I'm not anti-support group.
No, I'm with you on this one.
But yet sometimes the loudest voices in a support group are the most negative ones or the ones having bad side effects. Like some people find it helpful, but if you are finding it not helpful, that happens too, and maybe back off.
Yeah, on the mental health side of things, again, not a professional here, but we used to see it I used to work with veterans. And if I put a bunch of veterans together, they're typically fine. It's when I put veterans near other PTSD people, I would find that the individuals who have like very traumatic experience who aren't a veteran, they're very excitable. And that is what would trigger the veterans because they're very caring people usually.
Right.
And they see someone else and they're like, they get antsy about it. Yeah. So I can see like if you're in the knitting support group and you're all just knitting, probably mellow, right? But if it's a specific support group, be mindful of, when I talk about mental health stuff, I talk a lot about the language you're surrounded by.
Mm-hmm.
Right? If you're around negative language all day long, you're gonna have a negative outlook.
Mm-hmm.
So I could see where that could go a
Mm-hmm.
little awry.
And I will say, beware my chart. So I have patients, we can all see our medical records now.
Mm-hmm.
And I call it's the red arrow sign. It's the little red arrow next to your lab value that tells you it's like out of range. And, on the blood work I look at maybe 30% of the values that are reported, because there's a lot of like information that's just not relevant. And sometimes the irrelevant stuff is what flags and people think they're dying. Or I did a CAT scan, someone's a year out from their pancreatic cancer diagnosis, do a CAT scan for surveillance, totally in remission, totally normal scan. But I've had patients look at the report, see the diagnosis code of pancreatic cancer, and think that their pancreatic cancer is back. So
be careful with your medical records. Like, don't, if you're concerned, be concerned.
Yeah.
Go to your doctor, talk to them.
Yeah. Or maybe don't look until right before your visit, because, I've had patients look 3 days in advance and not sleep for 3 nights because they think they're dying. And I come in cheerful. I'm like, everything's great. And they're like, I'm not dying.
Yeah, that could be a little bit of a teeter-totter event there.
Yeah. So just beware those things, because I feel bad of the amount of like needless stress that it causes people.
Interesting. Well, I mean, that kind of gets into our next question, which is obviously this stuff affects your life, right?
Mm-hmm.
I think I've known personally people who get the cancer diagnosis and they come in because they want to talk to me about it, not in like a professional level, but they're just kind of like, am I allowed to get body work anymore? Like, they have questions.
Mm-hmm.
And there's a lot of things that tie my hands on my side, and other practitioners, acupuncturists, their hands get tied a lot.
Mm-hmm.
Even just massage therapists who don't have any training, have no idea what to tell these people. These people just want, an individual just wants someone to be like, I just want to relax. Like, I'm so stressed out. I got this diagnostic. And then it could even be that they're just waiting on their results. It's like, well, are we allowed to touch them? Are we not allowed to touch them? So as far as balancing quality of life with a cancer, during cancer treatment, we're getting, a actual diagnostic or diagnosis, what would you make a recommendation there?
Well, I think, a lot of times patients, they'll come into me and say, when they get there, they want me to tell them how long I have to live. They have to live.
Okay.
And I'm going somewhere with this.
No, yeah, this is interesting.
Because there are two main situations, right? Are we in a curative setting or are we in a palliative setting?
Can you define those a little bit?
So can I cure it or can I not cure it?
Okay, so palliative, when they hear the word palliative.
It means you can't cure it.
Okay.
So any oncologist who is worth anything knows that. Am I curing or am I not curing? So for example, Hodgkin's lymphoma, 6 months, usually we pound you with chemotherapy and you're cured about 80% of the time. So I'm a little less, I don't want to say empathetic, but I'm a little less, I'm less likely to take quality of life into account, because I'm curing you with chemotherapy. It's primary
you have to
curative
get this
intent
done.
Chemotherapy, like, suck it up.
Okay.
I hate telling patients that, but sometimes the answer is, I know this sucks. You can do it. It'll be over in 6 months, and then you'll be cured very likely. So let's just do this.
Gotcha.
I'm part oncologist. Sometimes I'm part cheerleader. Now, if someone has a stage 4 cancer, a stage 4 pancreatic, lung, breast, whatever, then quality of life is the most important thing, because usually they have to be on some kind of treatment for the rest of their life, because we're shrinking disease, we're controlling disease. But in most cases, if you stop that treatment, the cancer will start to grow back. So it has to be tolerable.
So I think there would be advice on both sides. And it might not be the best idea for me to be drawing conclusions from what I'm hearing you say and then using analogy of bodywork stuff. But like when I talk about mobility and flexibility, that's the acute, that's like, suck it up. You just have to stretch, right? Like you have to lengthen this muscle. No one likes stretching. No one. I've never found anybody who likes stretching.
I like stretching.
Okay. All right. Fair. But like when I need them to actually lengthen a muscle, no one wants to put in the daily work to do that. But if you do it, like we're done. It's over. We don't have to go back. We've changed the proprioception. But on the other side of that, if it is something I deal with individuals who have something like rheumatoid arthritis, or I know I'm a Band-Aid. Like I am just a Band-Aid for their life. I think you're making a recommendation on both sides. Like, okay, on one side, suck it up, kind of deal with it. And no, I think everyone should understand she's not putting it that way to them, right?
Like in a more empathetic fashion.
Yes, exactly, right?
I believe
There's
the word
bedside
I
manner,
use
she's
is,
fine.
I need you to channel some resilience here.
Okay, all right. And then on the other side of that, when it does become palliative, and I think the conclusion I wanted to draw there is when people hear the word palliative care, we're really talking about quality of life at that point.
Correct. And like, well, there are specific palliative care physicians. Palliative care, I think, is a specialty that was created because medical oncologists and the other specialties sometimes too, we're so focused on the treatment of the cancer that sometimes we forget to give the patient pain medication, you know? And, you know, like in our defense, the treatments are complex, lots of side effects, potential drug interactions. So we're really focused on that, but you want to focus on the human, you know, their pain, their nausea, difficulty with sleep, depression that comes with it. So palliative care is like an adjunct to me to help get specialty training in managing the symptoms of cancer treatment. It does not mean I'm trying to trick you into going on hospice. Because that's what patients think. Like she said, palliative care. Am I going on hospice? No.
Honestly, that's where my mind usually is because I've worked with people in hospice care. So yeah, like that's usually, because that's what I wanted to bring up, like palliative care.
Yeah.
That is the conclusion that usually gets drawn. But really in this sense, it's more quality of life.
Symptom management, quality of life. Now, when you're on hospice care, clearly we're palliating there too. You know, hospice care is when we've decided to stop treating a cancer for whatever reason. There's no more treatments. The patient's condition has deteriorated to the point where it's not safe. The patient decides they don't want any more treatments. I always say like, okay, well, just because I'm not giving you chemo doesn't mean I'm not still treating you as a human, and you have to be ready for what it means to stop treating a cancer, you know, deal with pain, anxiety. You don't want to be floundering at home and end up back in the ER. You want those supportive services in the home to get the medicines you need to die a natural death with quality in the home, to die a peaceful death, not in a hail of gunfire in the ER, you know, on a ventilator.
Yeah. So realistically, when we're talking about that quality of life situation, people should be aware that these things exist. There are hospice care for that situation. There's other palliative care doctors. So when you provide them these resources, it's something they should give credence to. They should look into this, correct?
Correct.
Okay.
Yeah. So when your doctor suggests, like if you're on a cancer journey and they recommend that you see palliative, it's just an extra layer of support for quality of life.
Okay. And they really should think about engaging with that.
Yeah. It's just another doctor to help you manage symptoms.
Okay.
Now, back to the, you know, patients will often ask me, Doc, how long do I have? I always go back to, I'm a DO. So I always say my ID says DO. It does not say GOD. I do not know how long any human has to live. I'm right about 50% of the time. And time stamping a human being is terrible for their mental health. It's also terrible when you're wrong. I've had patients who lived longer than I said they would, and they were mad at me because of that.
I mean, I could see that happening.
They made plans.
Yeah. I mean, if you went and spend all your savings.
One did.
I could see that happening. Honestly, that would be like, if I'm being completely honest, that's what I'm doing. Like, I'm going to go that route. It's like, yeah, Japan, here I come.
Right.
But I could see that happening.
Yeah. So I really don't ever answer that question unless someone absolutely browbeats me and I try to talk them out of it. I try not to, because I'm wrong a lot, because patients surprise me all the time. I've had patients do way better than we think, and I've had patients do way worse than I thought. And like, who am I? Like, I'm not that arrogant to think I know how long another human has.
Interesting. As far as I'm seeing the correlation to our next question here. This is part of being a host is having to figure out how to progress in the segments. Is there a set of recommended timeframes for certain things that you are required to make mention to? Like if someone has a stage for this, do you have to say like, I think you have this long? Because I'm thinking of it in the sense of people always like to use movies as references, and they're terrible references. And so there's always that scene where someone walks in and they're like, "Hey doc," and they're like, "Well, you have this long to this long to live." So I think they're expecting that. Is there a standard, you talked about risk assessment charts as far as like what's your risk and how will it progress? We're going to get into genetics here in a second. Is there a set of timeframes that you're required to quote at all?
No.
Okay.
No.
So that's not a thing. Because I think everyone thinks that's a thing.
No. Like patients ask. Sometimes
I think that's why they're asking.
Right. Sometimes it's the first question they ask. And like the answer is truly, I don't know. Like I'm not avoiding your question. I don't know. Like I had a stage 4 pancreatic cancer patient. We gave him chemo for a year or two and it was just beating him up. And he had spread to his lung. We call it miliary spread. It's just like, it almost looks like buckshot in your lung. It's real tiny and like diffusely through his lung. And we took a treatment break for 2 years and that thing didn't grow.
Interesting.
Yeah. He lived way longer. And he didn't get immunotherapy or any of these newer things. This was pancreatic cancer 10 years ago when I was earlier in my practice. And his disease stayed, like I scanned him every 3 months. Nothing changed. And then it started to grow and he died of it. But he got 2 years off treatment and the cancer just behaved itself.
Interesting.
And it shouldn't have. So there's something to be said sometimes for like a treatment break, let people just get a little stronger, see what their cancer is going to do. Sometimes you get away with it. And we're going to talk about some of newer treatments like immunotherapy. Patients are doing so much better than they should. I have patients now who have no business still being alive with a stage 4 lung cancer 5 years later, still in remission.
Interesting.
So we don't know.
Okay. That is a fair assessment. It's like, yeah, we don't know.
Yeah.
Things we do know, I think is the next topic. So you have a background in this, and this is something I am massively interested in because the more we learn about this, the more we understand everything from how the gut biome works with the rest of the system, how disease progresses in patterns, how, people's just natural development happens, how we can look for development situations that wouldn't be natural to a genetic pool that now we can see a deviation from. So let's talk about the role genetics play in cancer risks and or if people should consider genetic testing.
Yeah, I'll give you a little history on that. So the gene, the cancer gene that everybody knows about is BRCA or BRCA. So there's BRCA 1 and 2. If you recall, like Angelina Jolie, I think she tested positive for BRCA2. She had bilateral mastectomy, oophorectomy, she had ovaries removed. So that was kind of like a famous person got it, a little more on everyone's radar. So the history of this is, genetic testing is usually done with the guide of a genetic counselor. So that is people who do a master's program in genetic counseling, genetics. They put the counseling in it because it's a really emotionally charged thing. A mom has a cancer gene that they have a 50-50 chance of passing on to their offspring. There's a lot of guilt with that. So there's a lot of counseling that goes on. So go back to early 2010s. We used to take a family history and then say, what's your family history consistent with, and test one gene at a time. Like breast and ovarian cancer in your family, we'll test you for the BRCA gene. But in, I think it was 2013, it was a Supreme Court case. There's a company called Myriad Genetics, and they patented the BRCA gene. And I guess their testing method for it too. And they were trying to say that you could patent a gene. So this test went all the way to the Supreme Court for them to say no, this is a thing naturally occurring in nature. You cannot patent it. So what that did was that opened up the field for competition. That competition made genetic testing cheaper. And now we do something called next generation sequencing, where we can sequence for multiple genes. They basically like take the blood sample and probe that sample for multiple genes instead of just one gene at a time for about the same cost as you could do it for one gene. So it got cheaper, it got more efficient, and it got more broad. So very rarely now do I ever send just one gene. You send a panel of genes. But it's important to have a little counseling before you do that, because understanding that if you are getting genetic testing and you yourself do not have cancer, before you find that out, you better get all the life insurance, all the disability insurance, and all the long-term care insurance you're ever going to want in your life. Because if you find a BRCA gene, they're going to either deny you or jack your premiums up. And it's a lot of times why we don't test children for genetic syndromes where we wouldn't screen for anything until adulthood. And I always say, like, even if you're going to get anyone tested and you're young, get a life insurance policy. It'll be dirt cheap.
That's fair.
Because you might not be able to get it. It's like you don't have cancer, but you have to report that you have the gene. If you don't report that on all the screening they do, it's insurance fraud. So you have to tell them if you know
so it is ruled that you do have to, as soon as you find out, you have to, if you get a policy.
Yeah, you have to tell them that. Yeah, it's the Genetic Information Non-Discrimination Act. So basically, like, you can't be discriminated against for employment or health insurance based on genetic information, but you are not protected for life, disability insurance, or long-term care.
Because at the same side that you can be protected for that, it is illegal for you to lie about it.
Correct. Yeah, it would be insurance fraud.
Okay.
So, now, if you're getting genetic tested and you already have cancer, like horses out of the barn, you're not going to be able to get a life insurance policy. But, genetic testing is important, like especially if you have a cancer. Now we have drugs that can actually target these gene mutations as part of cancer treatment. So, for example, if you have like a stage 4 breast cancer and you have a BRCA gene, there's these drugs called PARP inhibitors that it's kind of like a 3-legged stool and you knock out 2 of the legs. So if you have like a cancer cell that's already deficient, or it already has a mutated BRCA gene, BRCA codes for DNA repair enzymes. So that's why your cell got screwed up, because your DNA couldn't repair itself. PARP is also another thing that repairs DNA. So if you take that out, then the cell's so screwed up that it dies.
Interesting.
So, genetic testing is important not only for your family members, but for your own treatment. And I always tell a patient, I've had patients with stage 4 cancer who we know are going to die, and they get genetic testing and they find it in their children, and that daughter has a mastectomy or ovaries removed, and they never go on to get the cancer that they might have. So I always tell that patient, your death is not in vain, your experience is not in vain, because you actually help your family members.
Yeah.
And we have to have a cute term for everything. So people who have those risk-reducing surgeries ahead of time, we call them previvors. Because you got to have a cute term for everything.
That's fair. I think one of the important takeaways there that a lot of people aren't aware of, when we talk about genes and we talk about genetic testing, this is a realm of things that can be really complicated to wrap your head around, because everyone's like, oh, I never took a biology course. I have no idea what you're talking about.
But you've hit the daily limit for advanced voice.
That's Octavia. Don't worry.
Standard now.
That's fine.
Chatting.
That happens every once in a while. I'll have to cut that part out. There goes our co-host. Anyway, but if you've never taken a biology course, and honestly, I didn't. I never took biology. I took like 3 years of physics. When people talk about genetic testing and gene expression, they don't understand the differentiation there. And so when she's talking about you have these 3 legs and you kick one of the legs out, that's not necessarily eliminating the gene from you. It's turning it off. So we have the ability to kind of turn, like in simple terms, turn things on, turn things off. That's what's called gene expression. So the gene, you can have the gene, you can have the BRCA gene, which puts you at risk, but until that gene expresses, until it's turned on, you don't actually develop. And so it's important, like she was saying, if someone gets tested and they know it's in the family lineage, to have the other individuals get tested as well, because then we have the treatment set to be like, hey, we can monitor this, and we also know how to turn this off. Is that correct?
Well, you can do a risk-reducing surgery.
Okay.
So, like for example, with BRCA, breasts, they're easy to screen. They're on the outside. We don't need them for anything after childbearing. They're easy to operate on. Ovaries, not
Different.
easy to screen.
Yeah.
So if you have a BRCA gene, there's other genes like, Lynch syndrome is a colon cancer syndrome that's also associated with ovarian cancer. If we know you have that gene, then we can remove your ovaries and drastically reduce your ovarian cancer risk. So we just take them out.
Is there an age timing for that?
Usually, like for BRCA, we see after completion of childbearing.
Okay. And that's when they should start to discuss it with their doctors
Correct.
and make that decision then?
Yeah, and like with Lynch, there's different risks for all the different genes associated with that. The National Comprehensive Cancer Network has a website with guidelines, and that's kind of like my Bible. So every year those guidelines are updated, like usually around January, February, based on the accumulated data that we collect for any changes to screening recommendations, any changes for timing of risk-reducing surgeries. Many people don't know even, like, BRCA is also associated with pancreatic cancer, so now we screen for pancreatic cancer.
Interesting.
So
Are they
yes,
finding a lot of crossovers?
Crossovers.
Like this gene has multiple expressions as far as the cancer goes?
Yeah. So, I mean, this is the culmination of a lot of data collecting, from the genetic testing companies. And also there's a publicly available site called ClinVar that it's like publicly available, what we know about each specific gene and its cancer risks. But yeah, I mean, BRCA is not just breast and ovarian, it's pancreatic, it's prostate, and it's melanoma.
Interesting.
So a lot of times people think like, oh, if I'm a man, I don't need to get tested or I can't pass it on to my children.
Yeah.
Not true. A man can carry a BRCA gene. They can pass it on with a 50-50 risk to their children, just like a woman can. And men can get breast cancer. So there are implications for men in screening with BRCA. Not as much as women, but still there are things we can do. And it's not just BRCA. We know of tons of genes now that have screening recommendations, colonoscopies, imaging, dermatologic screens. So there are things you can do. And the other nice thing is, so Lynch syndrome is a colon cancer syndrome. And we usually, like for the higher risk genes, we recommend colonoscopies every 1 to 2 years. So let's say mom has the gene. A lot of times, like the kids don't want to get tested because they don't want to know if they need colonoscopies every 1 to 2 years. But I also sell it as if you don't have the gene, then you don't need those.
Yeah, that's fair.
So 50-50, you may actually not need it.
Just
Those
find
risks don't apply to you. And isn't it nice to know that too if you fall on the right side of the 50?
That's very true. Yeah, this is interesting because when I first got involved with anything that had anything to do with genetics, I was doing something called folding at home, which was when they were taking, essentially it's just folding molecular structures, but they were using it for kind of mapping the human genome. And I had no idea at any point in time that that's actually what they were starting to use that technology for. Now, there's been some controversy about folding at home and this was 12 years ago, and it's kind of progressed different ways. But what we know now, comparatively, vastly different, which kind of takes us into our next question. We talked about how genetics play a role in cancer risks and also, should people be getting genetically tested? That guideline gets updated every year. What have you been seeing as far as cancer treatment advancements and different therapies? Is there anything promising coming out or what advancements have we made there that you've noticed?
Well, the big one is immunotherapy. And a lot of people throw that word around, but
yeah, I think we might need to define that
when
one.
a medical oncologist says it, here's what we mean. So someone much smarter than me figured this out. Cancer sends a message to your T cells. And that message is, nothing to see here. Don't look over here. I'm not doing anything. Leave me alone.
For those who need to know, your T cells are your hunter-killer cells.
Yeah, like the part of your immune system.
Yep.
And someone figured out how to block that signal. And then the T cells are kind of like, it's like a bouncer in a bar. Like, hey, what are you doing here? Get out of here.
I know what that's like.
Yeah. It turns on your inner Phils.
Thanks, yeah. I
to
sense,
kick cancer's butt.
I sense something over here needs to be dealt with.
Yeah. So basically it kind of takes the brakes off the immune system to attack the cancer. Now, ain't nothing free in terms of side effects. So when you take the brakes off the immune system, sometimes those T cells can cause autoimmune problems against you. And they can be serious.
Okay.
I always tell patients, anything can get an itis. Colitis, pneumonitis, hepatitis, nephritis,
For those who need
inflammation.
to know, itis means inflammation.
Yeah. So have I had patients who had diarrhea for 6 months because of the colitis I induced with these drugs? Yes. And then you're on steroids, and you have to be on steroids for months, and sometimes other immune suppressive drugs. So these drugs are not benign, but they are game changers. And a lot of times, like, I've had patients who I had to stop. They had like a stage 4 lung cancer. I was given immunotherapy, got an autoimmune problem. We had to stop. The cancer keeps shrinking months later because it's not like chemo. Give drug have effect, drug leave system, no more effect.
Yeah.
Immunotherapy teaches your T cells how to surveil for the cancer, how to control the cancer. So you can see effects of these drugs for months after you stop them.
And are they specific to a certain type of cancer?
There are, like,
or are they developing that?
Well, they're the original cancers they were tested in. This was probably like, I want to say around 2008, like mid 2000s. This really started. Are melanoma and kidney cancer, because like chemo just really doesn't work on those drugs. They're very sensitive to the immune system. And in fact, like before immunotherapy existed, like you can go back to the 80s where there are cases of stage 4 melanoma that spontaneously regressed and went away forever because something in that person's immune system turned on and killed it. And I think that's where some of these original ideas came from. So melanoma and kidney cancer were what they were originally tested in. They were then tested in lung cancer, bladder cancer, squamous cell carcinomas, which are usually like of the skin. That's a type of skin cell. We said melanomas, which is a different type of skin cell. Triple negative breast cancer, they have effects, which is like the non-estrogen sensitive ones. So after the original studies in the mid-2000s with melanoma and kidney cancer, we just started testing and everything. Places where they don't work, a lot of the like leukemias, like acute leukemias, we haven't seen much effect. We haven't seen much effect in ER-positive breast cancer. Those are two of the ones where like we've tested them, they haven't worked much.
So it's not a catch-all.
So it's not a catch-all, but it's a catch-a-lot. And like I said, patients who have no business still being alive are alive 5 years later because of these drugs.
And when did you start to see immunotherapy start to kind of come on to, I don't want to say the market, but that's just kind of the term we use as it comes onto the market. When did you start to see immunotherapy start, and what was the kind of education level for that?
Oh, I mean, it was terrifying when we first started using these drugs because, like, we didn't know about these autoimmune issues. Like, I had a patient on study who, like, died suddenly on the drug. And they actually went into, like adrenal crisis. Like, it affected their pituitary gland, and the pituitary signals to your adrenal gland for your like, stress hormones. And her cortisol level came back after she had already passed, and it was 0. It was like, so it's like,
I would like to chime in real quick because this is one that everyone hears these hot terms about cortisol. We cannot live without cortisol. It's part of the endocrine system, and a cortisol cascade is an event at which your cortisol levels hit a certain level and then they plummet. And that is when we see a lot of dysregulation in the body, and it causes a lot of harm. So I get people are trying to lower your cortisol levels, but cortisol as a whole, when you get your testing done, if you get regular blood work or anything like that, the only thing I can say is pay attention to it. If it's high, okay. But if it's low, it's also something to pay attention to because it causes all sorts of dysregulation. Sorry, that's just like a pet peeve of mine.
Well, and it's, so, and in the vein of anything getting an itis, in that patient's case, it was called hypophysitis, meaning it messed with the pituitary gland. So yeah, like we were using these drugs for the first time, just seeing what happened. Another thing we didn't know is, are vaccines safe with these drugs.
Oh.
Because if you think back to the 70s, especially like Guillain-Barré with the flu shot, which is like an autoimmune ascending paralysis, we were like, can you get your flu shot? So we let people get their flu shot. Nothing happened. Like it's fine. But at some point we just did it and saw what happened and it was okay. So, what was I saying? What was the question? I lost the question.
This happens. Welcome to doing a podcast. So we were talking about how immunotherapies came onto the market.
Oh, yes.
And then the education that came along with that. And some of this was clearly, it was a little trial and error, but it sounds like it was kind of almost thrown at the doctors to be like, hey, here we have this thing. It can be revolutionary or we might have problems with it. Is that kind of...
Well, welcome to phase 1 studies.
Okay. So this, I mean, clearly this happened in a study. There were study groups. They did papers on it. Sounds like you were doing some work during some of these?
Yeah, like peripherally, where I was training at the time, we were doing more like later phase, like phase 2, 3 studies, which are like you've gotten past the safety and the dosing and now you're looking at efficacy. But here was the other sticky wicket, was that immunotherapy sometimes causes inflammation in the cancer, and it gets bigger.
Oh.
So the way we usually would assess if something was working and every other type of treatment was give drug, cancer shrinks, drug is working.
Yeah.
With this, sometimes it got a little bigger first, and then like 2 or 3 months later would start to shrink because of that initial inflammation.
So that's kind of funny because on my side of things with bodywork, when we talk about therapeutic change, people hear the word itis, right? Or inflammation, because that's all itis really means. Or the new term on the market now is apathies, tendinopathy. That's just inflammation of something, inflammation of the tendon. But now they're talking about the layers, whatever. I'll get off my high horse here. But I regularly cause inflammation to areas because the tissue is dysfunctional and not getting enough blood flow or innervation.
I'm aware because I'm Phil's patient.
Yeah. HIPAA violation. No,
it's not a violation if I say
it's true. I cannot confirm or deny. That's my famous saying. Causing inflammation in an area brings in more fluid flow to the area and can help control the issue. So it's interesting to see that an immunotherapy would actually swell the area. I'm wondering if, this is all conjecture, if that has anything to do with being able to get the treatment into the area or allowing the T cells access to that cancer.
Yeah. And it's almost like, was the Willie Nelson song, was you got to know when to hold them and know when to fold them. Like with these drugs, if that happens, you can't panic and say it's not working. But that was like a paradigm shift in how we thought about cancer response back when we were just figuring these drugs out.
Interesting.
So yeah, it gave me a lot of angst.
I could imagine.
But luckily I was in training then, so I always had an attending physician to like back me up.
Okay. Well, I mean, that's helpful, right? Yeah. And we are going to get into your background a little bit, but any other treatments or new technologies that you're seeing or excited for?
Well, in general, so where things are going now is using a lot of those genetic sequencing things on the tumor itself. So there's 2 types of genetic mutation. Germline, you're born with it, BRCA genes. But then there's somatic mutations in the cancer. So like what happened to that cancer genetically to make it be what it is? And now we can use sequencing of those genes to find genes that we know we can target with medicines. So examples are, there's a pill for a gene called EGFR. There's a pill for, a very famous example of that is the Philadelphia chromosome in chronic myelogenous leukemia. So chronic myelogenous leukemia used to be something we did bone marrow transplant for, I guess, like up to the early 90s, I think. And then just kind of serendipitously, a researcher noticed a translocation of chromosome 9 and 22, and that's called the Philadelphia chromosome. And when you target that...
I love how we name these things, by the way.
Yeah, it was discovered in Philadelphia,
exactly,
that's why.
It's always like nodes of
I think
Ron
it was
VA.
Penn.
Thanks, Ron VA. Thanks for naming nodes after yourself.
Yes. So then a drug was developed called Gleevec, or imatinib's a generic, and then now we have a bunch of next generation of those drugs. And now we don't hardly ever transplant that disease because you basically go on a pill. It puts the disease in remission, and you just take the pill.
So it sounds like we're working towards a lot more targeted avenues.
Yeah. Yeah, I can't even think of the last new chemotherapy that has come into existence. Like, we're not developing new chemos because chemo sucks. Like, period.
If anyone knows, I think you get to make that statement. Yeah.
Well, I try not to gaslight my patients, right? Like, I try to come at them with a positive attitude. We're going to support you with like supportive medicines, and our nausea medicines have gotten a lot better. But like when the rubber hits the road, chemo sucks.
I had a client come in, and with doing what I do, you try to keep some level of distance, right? But a client long enough, like they want to tell you things. And this client felt it was necessary. He's like, I know I haven't been here in a while. I just wanted to tell you why. And I was like, hey man, come on in. Let's chat. Cause I had an inkling of what he was going to tell me. I didn't want him to do it over the phone. He felt like something he wanted to do in person. So we were talking about it, and he goes, yeah. And my oncologist, talking about chemo, and they're like, this is essentially what they said, Phil. They're like, it's just going to go in and melt everything. And I was like, interesting way to put it. Okay. I'm like, how did you deal with that?
Including your mucous membranes and hair.
So it was kind of just how they put it. I was like, yeah, it's just going to go in and melt everything. I looked at him, I was like, that's kind of accurate. It's kind of an accurate statement.
And I will say chemo sucks, but it often doesn't suck as bad as you think it will, because our supportive medicines have gotten so much better. Like 90% of the time, my patients don't vomit because we have good nausea prevention. And actually, not everyone has to lose their hair anymore because we have this cold cap that helps people keep their hair. So
this is where I'm looking right at you, movie industry, with this nonsense. Like everyone loses their hair and everyone's vomiting into the toilet. And that's anyway. Sorry. I think that kind of leads us into like, let's talk about some misconceptions and some myths that you'd like to debunk, because I have a feeling there's a few. I know a few I can think of, and I'm not even an oncologist.
Well, I promise you, the listener, that we are not hiding the cure for cancer to get rich.
Yes, that is not actually happening. I will agree with that. And people know how hypercritical I am of the Western medicine system. And it's not to say the practitioners or the treatments. That I'm going to make this solid distinction. I believe in Western medicine as far as saving lives, and the treatments, they are designed well. The diagnostic tools, just the MRI machine in general, and the things that we do to figure these things out. The education systems can fail in certain cases. That's my critique. But when it comes to cancer, no, like if we had the cure,
take the cure.
Yeah, that would be a thing. So any other myths, that's the big one. Yeah. I agree with that one.
Yeah, I promise we're not hiding it. Something I want to say to them, do you think that I studied until I was 35 years old to learn how to treat cancer so I could hide it from you?
Yeah. At the very least, take this as your doctor's not hiding it from you, okay? Their education system, if it does exist, that would be on them. It's not on your doctor.
And if you want to be cynical, if someone did discover the cure for all cancers, their ego and desire to get famous would never let it stay hidden.
It's true. It's very true, actually, yeah.
So, but other misconceptions is, I'm going to be vomiting every day. Our nausea medicines have gotten a lot better. It's a lot of times it's not going to be as bad as you think.
The same individual, he came back later and he was like, it sucked. But he's like, it sucked the amount I was expecting it to suck. Yeah. And then he was like, I'm feeling better. He had some side effects and stuff they were dealing with. But yeah, I've heard that story before. I've heard, they were going in expecting 1990s level of that. And it's 2020, people. We've been working on this. And if there's anything I think we should fund more, it's educational systems, as well as, there's a lot more research we can do here. But anyway.
I think other things is just going back to patients saying I have this or that long to live. For real, we don't know. And, I've had patients come to me with a new stage 4 low-grade lymphoma diagnosis. Those non-aggressive lymphomas, even at stage 4, sometimes we can watch them for years and only treat them when they're symptomatic. So, there are some stage 4 cancers that are curable. There are situations where a thing is stage 4, we can still cure it. So I would just say, when it comes to prognosis, curability, focus on like, are we treating with curative intent or are we treating with control or palliative?
So I think in that sense, how I would boil that down, I think most people, I get to say this because I'm not the professional in the room. I would boil that down. Like, I think most people, the myth there is people think I get a cancer diagnosis and I'm dead.
Correct.
Like the myth is if you have cancer, you're going to die.
Mm-hmm.
I don't think that's true anymore. It's a serious thing. I'm not
Right.
trying to make any light of it there. I just, like, if you get a cancer diagnosis, that's not a death sentence at this point. Like, there's a lot that can be done.
No, I just, listen to your doctor, and like cancer's not a monolith. Even a non-Hodgkin's lymphoma, there's like 30 of those.
I kind of say cancer is like quantum theory.
Yeah.
We've known everything we know about quantum mechanics since like the 1950s. Like this, we've done 70 years. Everything we knew back then is the same stuff we know now. All right. Like we've been at this a while.
Well, but it's like, Dr. Google, he's kind of my nemesis because, if you have a non-aggressive non-Hodgkin's lymphoma and you Google non-Hodgkin's lymphoma, you might stumble on the wrong subtype and be in a full-blown meltdown and think you're going to be dead in a month.
Yeah.
So, like, it really takes a lot of training to even know how to process the information you find online. Like, I'll give you an example. Sometimes I'll just like put the thing into Google and see what that AI thing tells me. It's wrong a lot.
Oh yeah. Don't ever trust AI for diagnostic stuff. And it also is going to always err for people who don't know how AI works. AI is programmed by individuals. And so we're programming the morals and ethics in on the AI side as the person would program it in, right? So if I'm a programmer and I want to put the large language model together for medicine, I'm always going to err on the side of serious because I don't want someone to suffer because I was wrong. That is pre-programmed into the AI itself. There's nothing artificial about it. And there's not really anything intelligent about it. It's an individual who programs a large language model, a bunch of matrices to say, here's a symptom, here's a possible diagnosis. Let's rank those serious to non-serious. It's probably going to give you the serious one because it wants you to go get medical attention.
Yeah.
So,
and I mean, even breast cancer, it's like 7 different diseases now. Like the big categories of breast cancer are estrogen sensitive, HER2 negative or positive, or triple negative.
So I think that would be a major misconception is like all breast cancer is the same. Obviously it's not.
Yeah. The main 4 categories are ER positive, HER2 negative, triple positive, ER negative, HER2 positive. But then there's some other subtleties as well. So I'll have a patient with estrogen sensitive disease stumble onto the triple negative, which is a much more aggressive type, and they think they're going to be dead in 2 years.
That's the one that I would say most women that I've dealt with, either professionally or even when I was training like female fighters and stuff, that's the one that scares everyone, right? It's the triple negative.
Well, and I mean, it's the more aggressive one.
Because I think it's the one you hear the most about.
Yeah, it's, there have been advances. Immunotherapy works for the triple negatives. So yeah, breast cancer itself is not a monolith. And like when I see a new breast cancer patient, I probably read that chart 3 times to make sure I read every little detail correctly, because there's a lot of subtleties to it. And a breast cancer in a 20-year-old or late 20s compared to a breast cancer in an 80-year-old, like even just age, comorbid conditions, how much treatment can I safely get into a person without harming them? The older you get, the harder chemo is. So literally every cancer is unique, and you have to take it in the context of its host and their medical problems and the treatments they can tolerate. So, it's truly one cycle of treatment at a time, one day at a time. I often tell patients, I don't even know what I'm going to do until it comes time to do it, because I have to see, how are you tolerating treatments? Are they working? So just the layperson going online and trying to like do it yourself, like I wouldn't do that to my plumber. So I wish patients wouldn't do that to me.
No, I think
because they get themselves very upset.
That's a fair statement. Because you brought up a word that I don't think people understand. Comorbidities. And so when you hear the word comorbidity, because this has been around I think COVID kind of brought that around a lot for people hearing like, what's this comorbidity thing? A morbidity is anything that can cause death, and we have a statistic for. A comorbidity is something that would add to the risk thereof. So obesity is the number one comorbidity on most, as far as I understand, any disease. The highest ranked comorbidity that most people have is obesity, right? Because that affects how the system works.
Problematic. But also, like when I'm looking at a new patient, think of comorbidity as your other medical problems.
Yeah, that's a better way to put it.
So like I'm looking at them like, does your liver work? Do your kidneys work? Does your brain work? Like it's really hard to treat patients with dementia with chemotherapy. Because if you can't remember yesterday, you can't remember you were nauseous yesterday, you can't consent to this thing that you have to be cooperative with. You can't tell me if your fingers and toes are numb and I'm giving you neuropathy and I don't even know it. So, I remind people, especially as people have aging parents with comorbids like dementia, the brain is an organ too. And if you can't consent, if you can't sit in a chair and keep an IV in your arm without tearing it out and understand why you're there, like it's hard to give chemo. So in the sense of like taking the whole person into account, when I see a new patient, I ask a series of what seems like absurd questions, like, do you dress yourself in the morning or does someone need to help you? Can you stand for an entire shower or do you need to use a shower chair? Can you walk up a flight of stairs? Like how do you use a cane? Do you use a walker? Like all it takes is someone who's prone to falls for me to give them chemo and they're going to fall. Or if you've already had 2 falls in the last 6 months, the Hippocratic Oath says, first do no harm. And if I kill you trying to cure you, I didn't do a good thing.
Yeah.
So, it's like sometimes I feel like patients feel like they're under the FBI interrogation when I first meet them. But like, I need to know.
But that comes with experience to know to ask those questions.
Well, I need to know, like, how's your chompers? Like, do you have a dental abscess brewing and I lower your immune system? And then we have a dental abscess and a bloodstream infection and you got to pour it in. Like there's so many things you have to be aware of when you are about to wield these poisons against someone and their cancer, and even targeted therapies, which, other targeted therapies that target certain genetic mutations in the cancer ain't nothing free. They all come with their own weird sets of side effects that we, are learning, with more use of them. So a really thorough review of systems, and truly knowing your patient, even knowing like, do you live alone? Can you get a ride to your cancer treatment? Cancer care is onerous. It's back and forth to my infusion room, back and forth for multiple appointments. And you can't always do stuff telemed. You got to see them in person. Like, do you have a spouse that comes with you as their extra set of ears to listen and write things down when they feel overwhelmed and scared? And I have, especially men without wives, coming into my office, I get nervous. And it's like my nurse almost becomes their spouse, calling them regularly, checking in. Are you taking your meds correctly? Like, can you read? Is English your first language?
I was just thinking language barrier.
Yeah, language barriers. But also some people can't read, so you can write the instructions down for them and they can't read it.
Yeah.
So, like, it sounds cliche, but you truly have to know the whole person. Is it a young mother with little kids at home? Like, these are the people who don't want to lose their hair because it's going to scare their kids.
Yeah.
Are they going to tell their kids their diagnosis? How are they going to handle that? What are your financial stressors? Do you need to work? Like, are you the person that carries the health insurance and you have to keep working? There's so many things that you have to take into account to successfully get somebody through something. And if you disregard those, then patients don't do well.
That's a fair statement. And I think that leads us into, you clearly have done this a while now.
Yeah,
and
14 years.
Yeah. And you've definitely, I would say you're, if not already mastered, some level of mastery has been accomplished here. And I talk about mastery a lot as far as, mastery is that 10,000 hours thing.
Yeah, there's definitely been that.
Yeah, at some point in time, you're like, all right, I've done this so long, it's almost intuitive in some cases. You know what to ask for, you know what to look for. How did you end up in the position you've ended up in? Like, what was the what was the schooling route? Because I think, people say, I want to be a doctor, right? Well, what is the more defined version of, I want to be an oncology doctor? So what was your route? Like, what kind of fellowships and training?
Well, my route was in high school, I had a really good computer science teacher. So I thought that's what I wanted to do. And we're still friends. And I yell at her for being such a good teacher. Because when I went to college for it, I did computer engineering and then kind of cut it back to computer science because engineering was not for me. I wasn't smart enough. And then I did an internship. And that was like around the year that Office Space came out. And I saw my future. If anybody's seen the movie Office Space, I was like, I cannot sit in a cubicle behind a computer all day.
Yeah, but you get a red line stapler.
Right. I do have one, actually. But so I think like advice I would give to anybody in college, in undergrad, do an internship and see before you graduate if this is something in the real world you actually want to do. So when I came back, from doing the internship, I actually had a series of very influential events around that time. My cousin, who I was very close with, he was like brother to me. He was diagnosed with HIV in the mid-90s. And I went out to visit him. He lived in Minnesota at the time. And his roommate, Jeff, was dying of complications of AIDS. And around that time was when there were a lot of breakthroughs with those treatments. And those treatments resurrected his roommate.
Oh, wow.
And it was just like, oh, maybe I want to do something like that. Like I want to do something a little more meaningful than writing code for marketing to support to see who gets telemarketer calls. Because that's what I was doing in my internship. So yeah, I came back and I called my dad. I was like, hey, Dad. I was three classes away from being done with a computer science major. I was a junior. Like, I think I want to go to med school. And he starts crying. And I was like, are you crying because you're happy or sad? I can't tell.
He heard his checkbook lighting on fire.
So he always wanted me to be a doctor. And of course,
all right.
I was not going to do it because, you don't do what your parents want you to do. And so he was happy. It did put off his plans for his Florida house purchase. But so I had to go back and take all the med school prerequisites of like biology. I was a little off cycle because the MCATs or the entrance exam you take for med school. So I took it at kind of an odd time of year. So I ended up taking a year off and doing like research in a medical toxicology lab and then started med school in the year 2000. So that was med school. So med school's 4 years. I went to osteopathic school. So like doctor of osteopathy and then versus the MD degree, which we call allopathic medicine, they're essentially exactly the same with the exception that DOs learn a form of manual medicine, which is, I don't want to say it's like chiropractics. It's different, but it's like the closest thing I can compare it to.
I'm going to hit the button. Hello, camera. Osteopaths are my favorite people because they learn manual manipulations of some level, not always chiropractic. There's other ways. And in other countries, we educate osteopathic medicine. There's certifications in Canada, certifications in the EU that are literally manipulation based, and that's the medicine that they practice. So I have a reason I like DOs. No offense, MDs, but DOs are usually more interesting.
Well, and that being said, all of my training was in allopathic programs, like oncology.
There's so much overlap, but I just like DOs are to me are always like, they have cool like things they're into.
Yeah.
So,
I mean, like having cancer is a contraindication for every single osteopathic manipulative technique. So like I'm a DO in degree only. All of my, once you go on to like residency and fellowship,
I think it gives you like
allopathic.
It gives you that kind of like whole body approach.
Well, and I will say osteopathic schools are a little more forgiving in their admission to people of maybe like didn't know they wanted to be a doctor from day one. Like a lot of people where this is their second career or they didn't have like a traditional path to medical school.
I think there's a lot of different outputs as far as, you can go on to chiropractics if that's really what you want to do. You can go on to more lab-based stuff that's a little bit easier to get into maybe than an MD would, because an MD is going to go be practicing allopathic medicine, whereas the DO can go into like more on the your kind of science background kind of gives more of that thing. So I think there's a lot more in the whole medical industry, what I can tell people is the outlets for what you're going to go do career-wise are vastly different than your little view that you went in with, because it changes so much.
Yeah, for sure. And like the osteopathic philosophy is being a well-rounded physician. So I have to take like extra like continuing medical education credits still to this day in pediatrics, primary care, GYN. Like there are specific credits I have to get in Pennsylvania because I'm a DO that actually aren't really related to what I do, but you learn something from it. You know,
and I think it exposes, like you said, like going in, like it exposes you to different fields other than like if you go in as MD track and you're like, I'm going to be a surgeon, right? Like,
it's the CMEs you need are definitely more focused. So medical school's 4 years. The first 2 years are usually the classroom. The last 2 years are like med students in the hospital. And then you do residency in internal medicine because you have to be just a good general internist to be an oncologist because of all the havoc you wreak with your treatments on all the other systems.
At that point, did you know you wanted to go into oncology?
Yeah, when I interviewed for medical school, I told them I wanted to be an oncologist.
Okay, so that was kind of your track already?
Yeah, because there is a ton of cancer in my family, and so that always, piques your interest. But I like pathology, like looking at stuff under the microscope, and you get to do a lot of that crossover in oncology, looking at blood smears and stuff. So, yeah, I always knew. And then getting into fellowship is the hardest.
And can you explain the difference between residency and fellowship? Because I think people use those terms interchangeably and they're not.
Residency is the first phase. Yeah. So, like, main residencies are internal medicine, surgery, like general surgery, pediatrics, like gynecology. Those are residencies. And then if you're going to subspecialize in one of those fields, then that's fellowship. So then to do hematology and oncology, that's 3 more years after residency as your specialty training.
And can you explain the fellowship process?
It's different where you go. Like, community-based programs, you're going to do a lot more direct patient care. To be a community oncologist is taking care of patients. If you go to someplace academic for fellowship like Penn, I think they do like more lab research. So every program's a little different, but it's, basically taking care of a lot of oncology patients, hematology patients, working in clinics, working in the hospital, working with bone marrow transplant patients, and getting some experience in your specialties. Like you'll do a month of radiation oncology, a month of gynecologic oncology. So it's a 3-year program. And then you usually have to do a research project, a quality improvement project, journal clubs, all that.
So there's a lot of extra work that goes into the fellowship.
Yeah, for not very good pay. So,
and you're working directly under a doctor or a team of doctors at that point.
Correct, yeah. So you're like under an attending physician when you're working. So you're still supervised. You're still
So it's
training.
Like being a doctor and a PA at the same time?
Kind of. Yeah, it is kind of. But, the way most people learn is by doing. So you just got to take care of patients.
And then after fellowship, you essentially go back to residency, right?
No, after fellowship, you're done.
But as far as now you're in your career and now
they call that being an attending physician.
Okay, so then you become the attending physician.
Yeah, and you got to pass boards.
Okay.
So I'm triple boarded in internal medicine, then 3 years later, hematology and oncology.
And so those were each, hematology and oncology are separate?
Separate boards.
Okay. And then obviously you have your continuing education you have to do. Is there any recommendations or advice you would give to someone who's looking at, I want to go do this? Or even if maybe you can generalize a little bit if you want to and be like, I want to go be this type of doctor.
You want to find a good mentor. And especially the subspecialties of medicine that are 3 most competitive are cardiology, gastroenterology, and hematology oncology. And sometimes it's a numbers game. Like the program that I teach at, we have 2 spots per year for fellows. We get 350 applications for those 2 spots.
Woo, yeah. That's competitive.
So it's a numbers game, and everybody's so qualified, it's so hard to pick. So you want to find a good mentor. You want to find somebody who will write you a good letter of recommendation, who has contacts with the different training programs. And especially if you want to go into a subspecialty of medicine, if you do a residency where they already have a fellowship program, you can get to know people to show them your a good doctor, and they'll often give preferential consideration for one spot to one of their in-house residents.
Is there any subspaces to the oncology space? Is there anything that would be kind of adjacent to that they could start with maybe and then move into oncology through?
Well, sometimes if you don't match in the fellowship, like some residents will go do either like a geriatrics or a palliative care fellowship for a year, and that makes them a lot more competitive to match than in hematology and oncology.
So there's some other options they can consider at that point.
Yeah, or even while you're in med school and residency, like trying to find even a mentor to do research projects to build that part of your CV, to get, some articles published and present.
CV stands for curriculum vitae.
Or resume.
Or resume. Now they call it a resume nowadays. But I will say, as someone who teaches or has taught in the past, a curriculum vitae, it's a good thing to have. So we were talking about, so you did your fellowship and then you became an attending physician, and then from there, we were talking about some differentiations that people can get into as far as like, they're going to be a fellow over here before they get back into oncology. You currently have fellows under you, correct?
Mm-hmm.
Is there what are the important lessons you learned in your fellowship or that you try to impart to your fellows?
Well, I always tell my fellows, the more behind.
There you go. Yeah.
I always tell my fellows, the more behind I am, the slower I work. Because there's those days when you're an hour behind, and I try to tell patients and tell fellows too, every patient gets the time they need. And when they're angry, you just tell them if they've had to wait for an hour that they'll get the time they need to. And I've learned that my mood sets the tone for the entire office. So if I'm being hysterical and stressed out and having F-bomb meltdowns, it rubs off on everybody else. And it causes you to make mistakes. Because my whole day is a conspiracy to make me screw up because of the amount of interruptions,
just the information.
Yeah. It's just you're doing one thing, someone asks you a question in the room, and then the way we page each other now is through the computer system. So a message pops up on your screen, you need to sign these orders. So I try to just slow down, do one thing at a time, finish the thing I'm doing before I do the next thing. And unfortunately, everybody's going to have to wait for me. It's just the way it is.
Yeah.
And I also warn them about the timestamp of people when patients are asking how long they're going to live. I try to teach them how not to answer that question because we don't know. And to sit when you're first in training or when you're first in practice after training, those first 6 months are the biggest learning curve of all when you're an attending because you're finally doing it on your own with no one watching you for the first time. And I had to get over telling a patient that I don't know. I thought I had to know everything.
That's my favorite answer to all questions is the answer I don't know because it's honest.
Yeah.
And the follow-up I always like to hear is I don't know, but I can find out.
Right. Or sometimes I will just flat out lit search it in the room with the patient. I won't Google it. I will literature search it. So, because if you don't know, it's worse to just make up an answer to seem like you know what you're doing.
No, that would be the worst thing ever.
Yeah.
Because I'm drawing.
I'm not a politician. I'm a doctor.
I'm drawing some clear conclusions between when you talk about having fellows under you and having this timeline situation. It sounds a lot like when I worked in the restaurant industry and an order comes in and time in a kitchen is 3 times faster than time outside that kitchen.
It's being in a black hole.
Yeah. You're I have to get this done right now, do this right now. And the realization comes after you've done it a long time to be that person literally just their order came in and I'm 10 minutes behind no matter what. They're literally just getting their first sip of their drink for the day. Their time frame is vastly different than my time frame. So it sounds like there's a little bit of a similarity there. What happens in the room and then outside the room. It's almost like you're the manager of not only the client, but then the department and then all this other stuff. So
because when you're in with one patient, all the needs of your other patients, which are thousands, do not stop.
Yeah.
So yeah, it's that's what I try. It's my mantra is I'm going to do this thing, then I'm going to do the next thing, and I'm going to do one thing at a time, and people can wait. And it's the, you have, your military adjacent.
Fair.
Triage is
Yeah.
important, knowing how to appropriately triage, like whether it's on the battlefield
Yep.
or just a list of tasks that are coming at you fast, like knowing what you have to actually stop and deal with right now and what can wait.
Yeah, one of our biggest sayings when I trained for private security and doing like medic work is like, medic always has to take care of themselves first, right? Like if I go down, the whole team goes down. Like that's just how it runs. But now again, I will mention it was non-military security, domestic side, so it wasn't that serious. But I also took away, and this is probably true for what you do. First things first, second things second, right? Like everyone's always trying to like make like no. First things first, second thing is second. Like you do them in order.
And it's like if you're switching back and forth between tasks, you're switching back and forth between patient charts, you can put the wrong order in the wrong chart.
There's mistakes are going to happen.
Yeah. So I really try to just zen myself, do one thing at a time.
Yes, we like the Stoic, yeah.
And like truly, it's not that I don't care how long people wait, but I don't, like it just is what it is, and everybody will get my time and as much as they need of it. But the flip side is you have to wait for me sometimes.
No, I think people would agree that's fair, and I think that kind of takes us into I like to finish up with maybe some more lighter topics. So, given your profession, what do you do to stay sane?
Well, I started doing yoga in 2005, and that was about when I started my internship and residency. So I found it at a good time, just taking time to settle your mind down. So when I go to my yoga class, the squirrels are running around in my head for about the first 45 minutes of the 60-minute class. But by the end of that class, I've gotten my mind settled down and I'm breathing and doing everything that I should be doing in a yoga class. And I don't beat myself up about the list making and the anxiety and the squirrels in my head if I don't get there till 45 minutes in.
I think it's a really good point to make that people think they should go to yoga or go to a mindfulness class or anything like that. And as soon as you're there, you have to be as soon as you walk in the door, no, the process is there to help you get to that point. You don't have to start there. That's a good point.
Yeah, no, it's like hardcore mania for the in my brain for the first 30 minutes and then it starts to settle. I get regular massages and
Good.
I come to Phil.
She does come. Yeah.
Yeah.
Although I wouldn't consider that a stress reliever.
Yeah, but being able to walk and move my arms is
fair.
Contributes to my well-being. And I actually play ice hockey since college, and I will say ice hockey is a really difficult sport, and it is the only time I am truly at peace. Because when you are skating as hard as you possibly can to try to get to a puck before somebody else, I'm just trying not to fall down and I can't think about anything else. I can't think about work.
Kind of like a meditation.
Yeah, it's like a very anaerobic meditation.
But this isn't contact ice hockey, right?
No, women don't check. I mean, there's contact, but we don't check.
I said that facetiously.
I'm in an old lady league now, so
there's nothing wrong with that.
There are no
I don't think you get to call any hockey league an old lady league. I would be afraid of these old ladies.
Three women on my team are over the age of 60.
I'd still be terrified.
No, we're very nice.
Still playing hockey. That's not at that age. That's someone I should be worried about.
That's why I come to you.
Yeah, that's true. I've seen these injuries. Is there any other health and wellness activities that you really enjoy doing?
I think, just some kind of movement. So to share the way that Phil and I know each other is a good friend of mine who is also my personal trainer. She comes to my house twice a week and we exercise in my either driveway or basement.
She tortures her.
Yeah. But, picking up heavy stuff, keep moving. When I don't feel like it, I just say, remember, you're going to have a catastrophic illness one day and you got to be able to get back up out of bed when it's been treated.
Look, it's honest. It's true. I've spent my career recovering from injuries.
Yeah. So it's just I could work 24 hours a day, 7 days a week. My work is literally never done. So having set scheduled times to stop and exercise, and they are non-negotiable. And even if it's just 1 hour a week, the best exercise is the one you'll do. And 30 minutes is better than 0 minutes. 10 minutes is better than 0 minutes.
No, I mean, I agree with all of that. That's like, you said one of my favorite things. It's one of the part of the Stoic Bodywork training method is the workout you're going to do is the best workout to do.
Mm-hmm.
And on that, the stepping outside of like the routine is something I tell people not to do, right? Like just keep it in the routine. Like just keep it in the, I'm going to do this. Maybe it's a certain individual torturing you whose name shall not be named. But what are the things that you hate doing?
What do I hate doing?
Like as far as health and wellness, is there anything like, you're like, I hate doing this?
Oh,
like eating broccoli or something like that?
I hate eating healthy.
Eating unhealthy.
I recently had some significant weight loss, and I will fully admit that I'm on semaglutide.
Hey.
I am a drug addict with food. I am a drug addict with sugar.
I mean, dopamine is a very addictive thing.
Yeah, the Ozempic helps. But yeah, I actually don't eat that healthy. I mean, when you're around Christmas time in any medical office, there's going to be cookies, donuts.
Yeah.
Like patients bring you the most unhealthy food. I eat it.
I mean, look, I'm going to say directly to reps out there, stop sending donuts to the doctor's
Or
office.
giant crumble cookies.
Yeah, like send a fruit basket. If you're going to send the donuts, at least add the fruit basket, right? Every rep in the world I've ever known, like every marketing, like, oh, let's send them the terrible food.
Yeah. And I really, really love sugar.
I mean, who doesn't? Honestly, I take my sugar in the form of honey, but that's just me.
Yeah. So all that, my advice about eating healthy, I can't say that I always follow it.
All right. That's fair. One of the things I do know you love is you take regular trips to do some charity work. Do you want to talk about that?
Yeah. So for the past 3 years, I've gone with a private group to Guatemala. It's a medical trip because I'm there.
Yeah.
And sometimes like we there's one woman who's a physical therapist, another one who's a physical therapist, which I'm thankful for them being there. One year we had an orthopedic physician come because there's so many orthopedic needs. And I got to tell you, giving chemo for a living is not a real third world skill set. So
that's fair. You can see how that would not really translate.
Yeah. And this woman who runs our trips, she works with a bigger organization called Tree for Hope. And Tree for Hope does a lot of work with a girls' school called Hope Academy. Because in Guatemala, the girls only get to go to school after the boys go to school and if there's still room. So this is an all-girls school. So I actually sponsor a girl to go to school down there and also sponsor some kids in the village for like food. They get every 2 weeks, they get some food staples. So I sponsor that too. So I've done it for the past 3 years. And basically I don't know, it's tough because, you know, they come to me for advice and I got to be sure that the advice I give isn't tone deaf. Like this year they asked me to teach them to do self-breast exams. And they looked at me like I had 3 heads. Because what do you do when you find something in a country that gives you no health care? Like the only way you have health insurance in Guatemala is if you work for the government, but there's no social safety net for the elderly. You know, if you don't have health insurance through very limited methods, you have to pay for it. And like, it's only in the big cities. Like, how do you get there for it? And the women there shared with me that there's a lot of taboo around male physicians doing breast exams in women. Like your breast has to be basically falling off your chest for them to even look at it or examine you. Like there's no infrastructure for screening mammograms. There's barely a way to get a doctor to look if you feel something.
I imagine just getting down to a city for these things to be available is hard.
Yeah. I mean, getting from where we are to Guatemala City is like an hour and a half through massive traffic. You know, we're near a village with no running water and no, like, there's basically like holes in the ground for where you go to the bathroom. There's no electricity. So it's a challenge. The day I was showing them how to do breast exams, they wanted me to do breast exams on them. And I was just like, okay.
Like, freeze, hold on.
I was like, I guess there's no consent form here for me to treat you.
Yeah.
So we basically went in a closet and I did breast exams and thank God I didn't find any masses in anyone because like, what am I going to do then?
Yeah.
So it's it's really tough, and I want to like communicate to everybody here in the US and any first world country, like be appreciative of the health infrastructure you have access to, because people down there would kill for what we have here.
That's I've become, again, I'm hypercritical about the Western medicine system.
As you should be.
That's the education side of it, right? Not the practitioner side and not the treatment side. Our advancements in medical technology outstrip the rest of the world by like a 2.5 times magnitude, right? Like the amount of MRI machines we make every year, even though that's diminishing and it's limited for some reason or another that I won't get into, they exist, right? Like they probably have like 3 in Guatemala. Like I'm being facetious there, but
well, I did a medical mission in Honduras with my med school, and I think there's like a handful of CAT scanners in the entire country.
Yeah, who maintains them?
And for all the oncology patients there, a lot of them end up going to Miami to get treatment.
Do you see a lot of foreign physicians that come to America for oncology, like learning like how to treat and how they do they stay or do they go back?
I feel like most people stay. If they have the choice now.
Yeah.
But I think most people stay. There are some that go back and set up things in, their country of origin.
So we don't see a lot of oncology treatment projecting outside of like the EU, like the major power.
Like oncology care in third world nations requires a lot of infrastructure that just isn't there. These drugs are so expensive. So while you may see them have access to like old school chemotherapy, newer like immunotherapy, targeted therapies that just, you can't get it.
So even if you were making a recommendation at that point, you have to like jump back 10 years to be like, well, you might have access to this.
Yeah. Yeah. So I choose my words carefully in Guatemala because I don't want to recommend a thing that
they don't
I might as well recommend them get treated with a unicorn, they can't get it.
Although Guatemala might have unicorns.
Right? Yeah,
maybe they're going to be anywhere. They might
in
be
the
down
mountains.
There.
But a lot of what I do down there is like, I'll ask patients, like, what medicines are you on? Can you get them? Like, does your pharmacy have them? Can you afford them? And how
did you get involved with this specific school?
It was, this is a private group. One of the women in the group is in my yoga class, and I invited myself. I was like, take me on this trip. I'm a doctor and I speak Spanish.
Well, that's right. I don't know how personal you want to get with it, but you speak Spanish, yeah.
Yeah.
And that's because of your heritage, correct?
No. Well, my grandfather was from Spain, but I learned as an adult.
Oh.
So
that I did not know.
I would categorize myself as 80% fluent. Like I speak it well, but the answer back sometimes is a little confounding depending on how fast someone speaks.
Gotcha.
It's made me a more kind communicator in English because I have realized when you're not speaking in your native or mother tongue, sometimes you miss a word here and there. And if people slow down and speak slowly, like when I'm speaking to a Spanish speaker, I tell them, like, look, you better slow down and speak slowly to me, or we got to get that iPad interpreter.
Yeah, fair.
And we all hate that thing. But if you're not going to speak slowly, we got to get it. So
what are the biggest things you see with the girls down there that like help them?
Well, there's a lot of philanthropy for the girls' school with Hope Academy and Tree for Hope.
Like, can people donate straight to that?
Mm-hmm.
Okay,
yeah.
They have a website, I imagine.
Yeah. I mean, if you had any interest, you would just Google Tree for Hope, and you can donate to sponsor a girl at the academy. The tuition, it's like $100 a month for their tuition.
Okay.
There is food sponsorship for the village, so they come and pick up food twice a month. I think that's around $30 or $40 a month now. You can sponsor any child, not just a girl or a boy in the village. But that's just the group I work with. I mean, birth control and sex education, I feel outside of Hope Academy talks about that are limited.
Okay.
In general, if you make it to the 6th grade, they kind of think of that as like the equivalent of a high school education here, and the fact that you can basically read and write and go out and get a job. So, education through what we consider high school is not guaranteed for anyone down there.
Was this your first time? Like, was this organization your first time doing this type of work at all?
No, the very first time I did a medical trip was in Cuba, believe it or not. I did it with a religious group. We did a medical mission down there. Um, so yeah, that was interesting because we had to do it in secret. Because like the way I would describe Cuba is the derelict father who says, "I'm not going to take care of my kid, but you aren't either." So we kind of had to say we were down there to teach, but we did
We're checking out old cars.
Yeah, I mean, it's like it's frozen 1959.
Absolutely.
It's bananas. So that was the first time I did it. And then I did 3 times in Guatemala. And then I did last year Honduras with my old med school. I went with 18 medical students from my med school.
Oh, that must have been an interesting trip.
Yeah, it was interesting. It was cute because I'm very far out of the first and second year of medical school. So some of the questions they asked me, I was like, oh, like I remember when I didn't know that.
What was your experience like the first time you went down to Guatemala? Like, where were you mentally as far as like, I'm outside my country, I am a practicing physician, you know, like what was that experience like seeing like going from American style healthcare to being like, I'm in a mountain?
Yeah. It's the first time we went, I had an orthopedic physician with me and a physical therapist. So I actually relied really heavily on them because like these are people who 70-year-olds because the elders from the village would come and
so it just wasn't just the girls.
Yeah. So the actual place where we did it is in an orphanage. So there's a lot of kids but the elders would come one time that were there. Like they'll come like one day. And then if they've got some follow-up stuff for the other days, they'll come back. And these are like 70, 80-year-olds who don't see a doctor often and have been carrying heavy things on their head up a mountain their entire life. So like their knees are shot. They have probably cervical spinal stenosis. So like I said, I don't have a super third world skill set. So I relied heavily on them for their assessments. From a medical standpoint, just like identifying a urinary tract infection or upper respiratory infections. My second year there, I diagnosed clinically somebody with dengue. I was like, yeah, I'm pretty sure you have dengue, go to the hospital.
Yeah.
So there are hospitals that they can go to in like emergency situations. And she did okay, but sometimes it's just telling people when they got to go to the hospital. You know, I would go to the pharmacy and buy antibiotics, buy children's cough syrup, buy meds for scabies and lice. You know?
Yeah, just like general things we would think like, oh, I can just go to CVS and grab.
Yeah, over the counter. Like, you know, I would just go to the pharmacy and buy it for them.
Yeah.
You know, a lot of times we would have our friends like give us money for donations and I'd use that money or I just pay out of my pocket. So it's just doing what you can. The first year we were there, I did pediatric school physicals. So they gave us like a sheet of paper that they just kind of made up for us to write down a physical exam and recommendations. And I would just wrote my Pennsylvania license on it. No one actually asked to see my Pennsylvania license. But
I don't imagine they would.
Yeah, but I could have just been pretending.
Yeah.
Because at the orphanage where we are out of primarily, they get inspected by the state, but they get no funding from the state.
Gotcha.
So these kids need back to school physicals with like absolutely no support to get those physicals. So it saved the director like putting them in vans to a free clinic.
Yeah.
So they took my physical as good enough for the state inspections.
Okay.
So it's just I go there and I see what needs to be done.
You just do it.
Yeah.
Now I imagine that provides some sort of reset for you, like coming back here. Having seen the dichotomy of like, okay, yeah, Western system dealing with oncology every day, and then seeing like impoverished, you know, no medicine, honestly. Like, what do you find fascinates you about the human system? Like, what pieces, like, what are some things you know about the human system that you don't think people actually like or take for granted or anything like that? This is like one of my favorite questions.
Not
easy, right? Kind of sucks.
It's not easy. It has nothing to do with Guatemala.
No. Yeah, this is just the human system.
So I had a patient once. He was young, in his 30s, and was diagnosed with multiple myeloma, which is a blood cancer. And what you usually do is give a bunch of targeted treatments. It's not standard chemo. And then you do a stem cell transplant. So I gave him 2 cycles of treatment. He went into remission really fast. but you're supposed to give a little more treatment and have the transplant. And after 2 cycles, he was a man of faith. He said, I believe God has cured me. I'm going to stop treatment. And I was his doctor for maybe like 5 more years after that before I switched jobs. And 5 years later, he was still in remission after something that shouldn't have kept him in remission that long. And I just thought to myself, I'm like, boy, if we had transplanted him, we'd be patting ourselves on the back saying, look, this guy's still in remission.
Interesting.
So I guess like it's just important to be humble, and patients will surprise you all the time. They'll not always follow your recommendations, and sometimes it still works out okay. And I just think to myself, like, boy, had I kept putting them through treatments with the associated side effects, I'd be patting myself on the back and look, they're okay anyway.
The amount we know about the human system is amazing. It really is. I mean, we know a lot, but there's a lot of things we don't know. And the more information we get, like the more things change. But yeah, just the amount that we actually still don't know. And that's why like I treat the human system as like, oh, physical health body, mental health body, spiritual health body. It's a whole different topic I don't get into. But you clearly have dealt with the physical and mental side of things for a long time. Anything you would like to add as far as a sum of the experience?
Yeah, I mean, what I've learned over time is check yourself before you wreck yourself.
Okay. I feel like that might apply to hockey as well.
Yeah. It's, like every week, not every week, maybe like once a month, I'll hear of a drug and I'll be like, what is that? It's like, yet another new medication in oncology. You just don't assume that even though you've had a lot of years of experience that you know everything. Always go back.
We call this the white belt mindset. Yeah.
Yeah. Like, exactly. Like you're seeing a patient and sometimes like they'll ask me about a thing I've never heard of before. And like, go back to the literature, review the literature. Even if you think you know it, read it again, make sure you're not missing anything. It's just like, you definitely have to stay humble and like, don't think you know what's going to happen. Like the patients will surprise you every single time. There are patients who make decisions about their health care that I do not agree with. And believe me, I let them know it. But you also have to respect people's decisions. And there are times when I've had patients refuse treatment and family members are freaking out. And I just tell that family member, don't ever force someone to take treatment that they don't want, because if they get a life-threatening side effect of it, then you're guilty.
Yeah.
So I just try to educate patients to make the decisions I think they should make. They're not always going to. I don't take it personally. I try to work with them in the context of the decisions that they make. And sometimes they don't do what you think they should do and they still do okay, and just keeps you humble.
I think that's staying humble, I think, is something anyone who I think it's universal to treating people therapeutically, right? Staying humble, a sense of like, I don't know everything. I act like I do sometimes, but at someone at your level to say that, I think should resonate with a lot of people. Like, hey, this is a person who deals with, like, let's be honest, death on a regular basis. To stay humble in that situation by managing both expectations of a patient, expectations of a family member, expectations of your staff, yourself. If that person's telling you to stay humble, then yeah, you probably should take that and call that a principle understanding. That's a lot. Anything else you would like to add as we wrap up?
The only thing I would add would be get your mammograms, get your colonoscopies, don't smoke.
Those all good. Yeah.
Go to the GYN on a regular basis. Wear sunscreen.
Fair. Thank you.
You're welcome.
Super appreciate you coming on. There's a lot of good information here. Is there any resources you would point anyone towards as far as like things to read up on or anything like that you would want to mention?
I think a good website is cancer.gov.
Oh, okay, perfect.
That's like the NIH website. If you have like for blood cancers, leukemia, lymphoma.org, those are all good resources.
Oh yeah, or any other organizations you would like to mention as far as like the Leukemia Foundation is one I have mentioned in the past to be like, yeah, if you want information or if you want to help with the research level, that's kind of like
I mean, you can donate to those things. But yeah, I mean, there's so much misinformation swirling around out there. So you want to try to like, stick to the, like the scientifically based resources.
That's why I like to get it from a doctor because they're usually the ones that actually have to deal with these in some way or another. Like you clearly deal with, and the NIH, like that's something you would have to have dealt with.
Yeah, so, like the National Comprehensive Cancer Network, nccn.org. I think they have patient resources on there, but that's like a thing I go to on the regular. That's our national guidelines. So those are all good resources for scientifically based information.
Awesome. I appreciate it. Thank you very much. As a reminder, everybody, the podcast is in part sponsored by purebulk.com. We're an affiliate of theirs, and you can use the code Stoic Bodywork to get 10% off any order as far as it goes with getting any supplement you could possibly think. Pure Bulk has it, so check them out. Check us out on the next episode. Every guest episode is followed up by a episode with me, just kind of going over some of the things I found interesting, as well as information that I didn't know or went and researched afterwards. So check us out on the next episode, and thanks for joining us. Take care.